Okay, so what I want you to do, I want you to start out with, is everyone has their heart. They are 3D printed hearts cut in one of the 4 resuscitative TEE views. Okay, so each one has a different slice there. I want you to hold your heart in the anatomic position in front of your chest, as if someone like Indiana Jones, your heart straight out of your chest. How would it kind of come out in front of you? Okay. Great. So there's a few things that can help us out. So looking at the back of your heart, we see a vessel that's coming straight down here. What's this? The descending thoracic aorta. Exactly. So we know that that's going to be kind of the most posterior structure. It's going to be kind of straight up and down before it curves over into the arch. Okay? So everyone's going to get a probe now. Okay? So take that probe, holding your heart, and advance it down the esophagus. Tell me kind of where that's going to be in your heart. Exactly. So turn yours around for everyone to see. So what you've done is you've put the probe right down the esophagus, and tell me about where it's located in relation to that descending thoracic aorta. So that thoracic aorta, descending thoracic aorta, is located to the left and slightly posterior to your probe. So if we had the vector that comes down out of the probe, would you be able to see that descending thoracic aorta? You'd have to do some rotation, right? Because it's located, you rotate the probe to the left, it's located posterior to you before you're able to see it on your screen, okay? So that's what we're going to think about, thinking about you as the probe within the esophagus and where the different structures are located spatially, whether it's in front of you, behind you, to the right or to the left, all right? Cool. So one of the ways that we have tried to conceptualize this is by looking at CT scans. So we read CT scans all the time, right? And we know that we read them. This is on the left side of the screen from the feet, right? And then the head is extending through the screen, okay? So if I take this image and I flip it 180 degrees, I'm now reading this CT scan from the patient's head perspective with the feet shooting through that screen, okay? And this is how we want to think about TEE, coming down from the head through the esophagus, okay? So here we have the normal chest CT on the left side of the screen. Here we have our rotated view of 180 degrees. We're coming down from the head, and we're heading towards the heart here. And we can see again, I'm going to steal your heart for a second, and your probe, that here we have the descending thoracic aorta just to the left and posterior to the esophagus, where your probe sits, okay? One of the things that makes this tricky, of course, right, is that we don't look at the vector screen like this on our ultrasound machine, right? So now we have to flip that all the way around so that we can see what we're looking at on the ultrasound machine, okay? So a lot of flip-flopping, but if you think about that you are the probe, you're coming down the esophagus, the vector and your heart is in front of you, it's going to help you out, okay? One of the points that we want to make about the mid-esophageal views, those are 3 of the 4 main resuscitative TEE views, is that the left atrium is our scanning window to the world and the heart, okay, within those particular views, all right? As you can see here, the left atrium is closest to the esophagus where the probe lies. So if I was to give you this vector here, can you draw for me where you might see the left atrium? Exactly. It's going to be in that near field because it's closest to the probe. Perfect. All right. I'm going to switch over to this HeartWorks computer. In the meantime, everyone take a vector. All right. So, holding your vector, and just to kind of keep it equal amongst everyone, put your blue side on the right side, your right, because you're the probe, okay? Cool. So I want you to show me, if you were coming down with your vector, what 45 degrees looks like.
Say it again?
Show me an omniplane that you changed to 45 degrees. Exactly. So you want to drop that right side. You're moving inferiorly on the right. They talk about changing your omniplane in a clockwise direction. That can be confusing, right? Because when I'm thinking about my clockwise direction, it's like this, but I'm looking at you, and that looks counterclockwise. So if you think about you, yourself as the probe, moving in a clockwise direction, I also think about my right side is going down, which helps you when you start to get those upside down views beyond 90 degrees, okay? So can you show me 90 degrees on your omniplane? Yep. So starting at 0, can you show me 120? Exactly. And 145s. Yep. Great. Exactly. Okay? So we're going to be dropping down on that right side to get any of our omniplane views. Okay? Cool. What we're going to do is go through the major valves and vessels that we see in the heart as we're just dropping the probe at 0 degrees of the omniplane, not moving anything. Okay? So first thing that we're going to see here are 3 branches that extend off the aortic arch. Are you able to label these branches for me? Brachiocephalic? Yes. I don't know it in French. No, it's okay. That's cool. What's the next one?
Carotid, left carotid.
Left carotid, yep.
Left subclavian.
Exactly, yep. So we take this, right? And it helped you to kind of have this in front of you. And then I take this, putting that up on the screen, it's going to be your right side. So we have the brachiocephalic trunk that then splits further up into the right common carotid and the right subclavian. We don't see that on our ultrasound. On the left side, you have the left common carotid in the center, and then the left subclavian off to the left. Okay? Coming down, what's the next thing that we're going to see?
The arch.
The arch, the top of the arch. So this actually, on every one of your models, is where they're cut. That's going to be the long axis on the top of that aortic arch. So all I'm doing is just advancing my probe here, and I'm seeing that long axis of the arch. Okay? What is the next major valve or vessel that we're going to see? Pulmonary artery, exactly. The pulmonic trunk. So think about that arch as a rainbow, okay? The pulmonic trunk will be cascading straight through underneath in its long axis, all right? The aortic valve and the pulmonic valve are perpendicular to one another, okay? So we're seeing that pulmonic valve in its long axis first. So we'll kind of dive down here, and you see that pulmonic valve coming straight underneath the arch. What is the next thing that we're going to see? So we've seen the pulmonic valve. What's the next valve or aortic valve, right? So knowing that the 2 valves are perpendicular to one another, we've just seen the pulmonic valve in its long axis. Is the aortic valve going to be in its short axis or its long axis? Short axis. They're perpendicular to one another. So we're just staying at 0 degrees, advancing the probe, and we see that aortic valve in its short axis. Okay? What is the next valve that we're going to see? We have 2 more, so it's a 50-50 chance.
Mitral valve.
Mitral valve. Excellent.
It looks close together.
Yes, yes. Okay, so a lot of us are used to using transthoracic echo, right? Okay, so we have our tricuspid valve here, we have our mitral valve here. And I've had a lot of people say, well, you know, I think we're going to see the tricuspid valve first. It's higher, right? So on TTE, it is a little higher, right? It's located closer to the apex. On transesophageal echo, knowing that you are the probe and the heart's in front of you, where is the apex located? Is it located close to you or is it further away? Further away. So that kind of helps to explain why we're going to see that mitral valve first before we see the tricuspid valve. So all I'm doing here is advancing the probe a little bit further. I start to see that mitral valve first, and I see this aortic root, okay? You can get a apical 5-chamber view on transthoracic echo that you won't be able to get at this position on TEE. So know that when you're seeing that aortic root, you have to advance the probe a little bit further. And this can be important if, for instance, you're in a resuscitation, they're doing CPR, and you have 10 seconds that you need to get that 4-chamber view. What would you do if you saw this and you wanted to get a better view? Advance the probe. And just by advancing the probe, that aortic root's going to go away, and now you're seeing your 4-chamber with the tricuspid view. Yeah?
Yeah.
Cool. Okay. We're going to go back to the PowerPoint. Great. All right, everyone can have their vector back. I'm going to open it up again. Okay, so we went through this. You guys will be able to take me through it. So starting out at that brachiocephalic trunk, there is something that can cause this problem, and that is the trachea. What's inside the trachea? Air. And what does air do to ultrasound waves? It scatters them. So there's a point at which where those 3 branches enter the aortic arch and where that pulmonic trunk comes underneath, on a real person, we're going to lose that image because of air scatter, because of the location of the trachea and the bronchi. As you advance the probe, it's going to get better. But where exactly you have the dropout depends on that patient's anatomy. You're not going to see that dropout in these simulators. It's going to be beautiful. You're going to see everything, okay? But be aware that this is a problem in a patient that is alive, or at least intubated with air going in and out of the trachea, okay?
Mainly is the last part of ascending.
So, yeah, right at that, at the ascending aorta and at the lower edge of that aortic arch. So, yeah, you're going to get some dropout there. Starting at the brachiocephalic trunk, what's the next thing I'm going to see?
Arch.
Arch, what's next? Pulmonic valve shooting through underneath the arch. What's next?
Aortic valve.
Okay. In its short axis or long axis?
Short axis.
Okay, great. What's next?
Mitral valve.
Mitral valve. And then finally? Exactly. Okay, great. So who has the mid-esophageal 4-chamber view? Excellent. Okay, you're up first. So put your heart back together. Hold it in your left hand in its anatomic position. And then in your right hand, take your vector and tell us how you're going to get to this particular position. To get to the mid-esophageal 4-chamber.
Lower down through all the structures that we just
Yes.
until I can see both valves, tricuspid, mitral, and the atrium.
Yes.
In that, the same plane that I went in, they need to retroflex.
Yes.
Yeah.
So, holding this on the side of the heart that you're holding in its anatomic position, if I'm coming straight down, this does not match up to the cut that's made here unless I were to retroflex a little bit, okay? So your risk of foreshortening the apex without having a little bit of retroflexion, that allows you to kind of get the full expanse of the left ventricle. How would I improve this view? More depth. And where do I change that depth?
In all the
On the machine, all the way around the machine. Nothing to do with the actual probe. Exactly. So we adjust our depth and now we get this beautiful image. Know that during active CPR, avoid any flexion, anterior retroflexion. That's because you're already having external forces that are causing some sort of flexion and movement of the probe, and you want that probe to be in the unlocked, flexible position so that it can be moved wherever. Certainly, once you've obtained ROSC and you want to get this beautiful 4-chamber view, you can add a little retroflexion, but you don't necessarily need it during active CPR. Okay, great. Who has the transgastric 2-chamber view? Great. So holding that in your left hand and taking your vector, tell me how you're going to get this particular view.
0 degrees.
Yes.
Going down, see the major vessel structure. Then go for 4 chambers, and they go deep, approximately 35 centimeters.
Mm-hmm.
And then I had to cut LB and RB.
Yeah.
0 degrees.
So you're going to actually go even a little bit deeper than that, but the natural curve of the esophagus and that back wall of the stomach will push the probe within this curve, okay? If I move this over here, kind of come up, drop it a little bit deeper here, and I'll turn the heart over this way, you're seeing this natural curve of the probe, okay? The problem, though, is that what kind of things are in the stomach? Air, food, stuff. Air causes us the most problems, and especially if this is a person that's been bagging at a certain point and there is some air in the stomach. You can get washout. So on these simulator machines, you just thread it down. Oh, it's beautiful, right? On a patient, you may need to do a little bit of anteroflexion, okay? Anteflexion here. And that's because you want to make contact with that anterior stomach wall there, so that you displace any air that could have collected in that area. Okay, so it can be a little bit difficult on actual patients. So sometimes we'll insert the probe, a little bit of flexion. Do I see anything? That's not great. Come back to neutral, maybe insert a little bit further, more into flexion to try and get this view. Okay, all right. Are you able to label for me with an A where the anterior wall is? So put a little A near the anterior wall of this particular view, right? My patient has come in a cardiac arrest and I'm concerned about a massive heart attack. So I want to know what my different walls are of the left ventricle. Excellent. Inferior wall. You got it. Lateral wall. Yep, and then septal. Great. Now, can you tell me if I had a myocardial infarction that involved the left anterior descending artery, where would I have wall motion abnormalities on this particular view? Mm-hmm. Yep, so we're on the septum, we're in the anterior part of the heart. Yep, send a little bit over here and a little bit up towards the septum. Perfect. How about the RCA? Excellent. And then the left circumflex. Perfect. All right. So I like these 3D models because they help us to kind of really look at what are the different locations and orientations of the heart, okay? So the heart sits like this, right? And normally we're used to thinking, oh, anterior, posterior. That's the opposite. However, when thinking about this left ventricle, this side of that left ventricle is more inferior than it is posterior. The posterior part of the heart encompasses these vessels. It encompasses kind of the butt of the right ventricle. So that's why we are labeling it anterior, inferior, lateral, and then septal. Okay. What makes this confusing, right, is that we see this exact same image in transthoracic echo. Okay. So will you label the anterior wall in a transthoracic view? Exactly. And then inferior wall in the transthoracic. Perfect. And then lateral and septal remain the same. But what that means is that our coronary vasculature is going to be opposite. So now the left anterior descending is going to be up here at the top. And our right coronary artery is going to be down here in the far field in the screen. Yeah? Okay. Cool. So this helps too, again, just to think about how is my vector going. There's this natural curve, right? This is the anterior part of the heart in the far field, and in the near field, that inferior part of the heart. Great. All right. Who has the vertical planes? And I'm looking for the mid-esophageal long axis. Great. Okay. So hold your heart in an anatomic position and kind of take us through how you're getting.
So advance your forward to mid-esophageal position.
Yep.
And then you rotate your omniplane. Now it's going to be this way. Rotating.
Yep. Yeah, 120, 140. So, let's say we stopped at 90 degrees. I can give this to you. Tell me which side is the anterior wall and which is the inferior wall. Perfect. Great. Okay. So now I'm going to take this, and we're going to get you to 120 to 130. I'll add a little aortic valve and something here. This is the RV. So tell me now, where is the anterior wall and where is the inferior wall?
Anterior is still going to be here.
Yes, exactly. And now we've added a septum, so anterior septal and inferior lateral. And this makes sense, right? When I'm using my plane, right? I'm coming down, of course, anterior, inferior, and now just a little bit, 120, 130, inferior left lateral, anterior septal. Great. All right, we have another one. That is the final bicable view. Take me through.
So going down to the mid-esophageal position.
Mm-hmm.
So maybe we center the right atrium
Yes.
and then turning 90 degrees.
Perfect. I can give you this. First of all, can you tell me what this is? Yeah, oh, this one up top. LA, perfect. The scanning window to the heart. All right. Can you tell me which is the SVC? Perfect. And then the IVC. Exactly. So you have rotated 90 degrees, right? And it's great because we kind of get this right in line here. SVC, IVC. Okay? Now, if I want to see more of the IVC, what am I going to do? How am I going to see more of it?
Push the probe.
Push the probe down. Just advance the probe. If I want to see more of the SVC, what am I going to do? Exactly. Mm-hmm. So don't need any sort of flexion with the probe, but it's merely advancing or withdrawing the probe. Great. Okay, cool. I think we're almost done here. If I were to be looking at the descending thoracic aorta, can you show me what you would do here?
Just over here, just after the arch.
Yep.
You can see it on the
Uh-huh.
left
All right,
side.
folks, we're going to rotate
Rotating
to our
around.
next
Yeah.
stations
Exactly. Mm-hmm.
for the 12
And then that would be
o'clock
the long
times.
axis.
Group one.
Mm-hmm. Exactly. So
Group
rotating
one,
to
you're
the
going
left
to
first,
Station C.
and then rotating
Group
down.
two, you're going
Exactly.
to Station D.
Nice
Again,
job.
Motion with draw
3, you're going to
Same thing. So it's a similar movement to that bicaval view. Rotating, turning, and then withdrawing or advancing to get higher or lower on that vessel. Great. Okay, thanks guys.